Good evening. First of all, I would like to thank West Bengal Academy of Echocardiography for inviting me here to talk on a topic which is very close to my heart. And I think this is for the very first time we are introducing fetal echocardiography session in this program. Is it right? Okay. So, fetal echocardiography, after the nice and colorful images of CT and MRI, we are going back to the basics of 2D echocardiography because that is the basic of imaging in fetal heart. Now, I know that most of the people here do echocardiography, but not many do fetal echocardiography on a regular basis. So I will keep my talk to the very basics so people understand and get interested and maybe take up the challenges in future. Now let us start with what is fetal echocardiography. We know that it is defined as a detailed ultrasound evaluation, and it is a specialized diagnostic procedure and extension of the fetal cardiac screening parameters. Now this is very important to understand the two terminologies. One is fetal cardiac screening, which is mostly based on the 4-chamber view and the outflow tract views, and fetal echocardiography. So we have to be very sure about the differences of these two terminologies. So what is screening of fetal heart? So all the babies, when they are undergoing the antenatal scan in the mid-trimester, around 20 weeks of pregnancy, they have an anatomy or anomaly scan where overall baby is screened for any congenital major malformations. And as a part of that scan, screening of the fetal heart is very important. And it started with 4-chamber view initially, and now the outflow tract views are also included. If you look at this video, I think everyone will appreciate that this looks like a normal heart because it starts with a 4-chamber view. You see that the two ventricles or atria are more or less equal in size as in mid-trimester. Then you can look at the outflow tracts, and the end of this video, you will see that there is a 3VT view. I will come into the 3VT view in later because not many of you are familiar with this. Whereas fetal echocardiography is a detailed study of fetal heart to find out all possible structural abnormalities. It also assesses the ventricular function as well as the cardiac rhythm. Now quickly I will go through the indications. You can find it in any of the recommendations from either American Heart Association, American Society of Echocardiography. This is the recommendation from the ISUAG, that is International Society of Ultrasound in Obstetrics and Gynecology. I'm not going into the details, but a few important things is when there is a suspected congenital heart disease in fetal cardiac screening, or there is a major extracardiac abnormality in USG, maternal diseases like diabetes mellitus, if the mother, father, or any of the previous sibling is affected with congenital heart disease, and fetal arrhythmia are the most important indications. Now, another important question is when to do. If we look at the ISUA guidelines, it is 18 to 22 weeks. Considering our country, there has been a modification in the PNDT Act recently, and now termination of pregnancy is allowed even up to 24 weeks, and it can be done later also with special permission. Considering that point and easier to diagnose the fetal heart abnormalities, 20 to 24 weeks is probably the right time to do the fetal cardiac screening and echocardiography. Now, most important thing is how to get good images. All of us who do echocardiography, if you get the images, then it is not difficult to interpret. And traditionally, the fetal cardiac screening and anomaly scans, these are done by the either obstetricians who are trained in obstetric ultrasound or radiologists. Naturally, the technique of getting a fetal cardiac images is different from the echocardiography in a child or an adult. So those who regularly do fetal ultrasound get much more beautiful images compared to us. So it is our duty to train us to get more beautiful images. Now there are some factors which are important, and I know that many of you may have tried to do fetal echo but did not pursue it because the images were not satisfactory. So let me start with the machine. I will not go into the details, but most of the echocardiography machine and the top-end ultrasound machines have fetal cardiac presets. So you should sit down with the application specialist and find out the best quality of images what you can get in the machine. What is important to use the curvilinear probe. As an echocardiographer, we use the cardiac probes, which are phase array probes. Those are not that good to get good images in a fetus. Again, grayscale imaging is the basic, but color flow and Doppler is required as minimum as possible. There are some patient factors as well. Both maternal and fetal factors are important and affect the image quality. One is definitely the maternal BMI and gestational period. It is difficult to get good images in early pregnancy or late pregnancy. So there is a small window when you can get the best of the images. If there is a fibroid or there is a previous scar on abdomen, that also can affect the image quality. Fetal position is very important. If the baby is in a prone position or the limbs are in front of the chest, you may get difficulty in getting good images. One thing is very important. If you are not satisfied with the images, then always repeat it. You can call the patient maybe after half an hour or 1 hour, and you can see the fetus in a more favorable position. And in spite of your best efforts, if it is not possible, you can call the patient another day, and if you cannot see an important structure, always mention that in the report. Now, approach to diagnosis is same as in pediatric echocardiography. So we do a segmental analysis of different parts of the heart from different views. Some are standard views, some may be modified views, as we use in our daily pediatric echocardiography as well. And we sum up all the findings to get the final diagnosis. What is the most important thing and difference between a pediatric echocardiography and fetal echocardiography is to determine laterality. So when we are seeing a child or an adult, we know which is the left side and which is the right side of the patient. But that is not true in a fetus. So one should first find out which is the left side and which is the right side of the fetus rather than directly jumping on the heart. There are different methods. You can use whatever is suitable and easier to you. What I personally use is to imagine myself in the fetal position. And if you can find in these pictures that if, take any of that, right? If you take the C, where the fetal head is down, so it is a cephalic presentation with the legs up and the spine is to the mother's left, then the left side is down. So similarly, you can imagine yourself in the position of the fetus and you can find out the left and right before starting the cardiac screening. Or you can use the fist also and imagine if the fist is the baby's head and the palm is facing towards the baby's abdomen, then the thumb will be pointing towards the left side of the fetus. Now, the most important view is the four-chamber view. We get the maximum information in the four-chamber view. And if you look at these three pictures, all are four-chambers views. We are used to get the apical four-chambers views. But in case of fetus, the advantage is that we can get three different positions of the fetus and we can get a basal four-chamber view where we are looking at the heart from the base. It can be a lateral four-chamber view where we are looking from the side of the heart, or it can be a apical four-chamber view as we are used to see. And each of them has their own advantages and disadvantages, and we should utilize that properly to get the final diagnosis. I'll come into the details of the four-chamber view later. Now, after determining the laterality, the next step is to find out that the stomach and heart are both on the left side of the fetus. That confirms the situs solitus. We also find out the size of the heart, and usually it is by eyeballing. The heart fills about 1/3 of the whole thoracic area. If you want, you can determine the thoracic area and cardiac area and find out the index. Majority of the heart should be on the left side of the chest, and the cardiac apex should be pointing approximately around 45 degrees. You should ensure that all the four chambers are present, and the cardiac rhythm and function, you should eyeball that those looks normal. And there is, if there is any pericardial effusion, you will be able to find out in the 4-chamber view. So this is the situs and axis, how to determine. If you get a cross-sectional view of the abdomen, the stomach will be on the left side, and if you find the relative position of the aorta and IVC, you can confirm that it is situs solidus. I am not going into the details, you all know. And the axis also you can see from the image. Then you should look at both the atrial and ventricular chambers. You should ensure the two atria, which are approximately equal in size in the mid-trimester, but as the gestation advances, the right-sided chambers becomes more prominent. One should identify the atrial morphology, because when we are doing echo, we should ensure the left-sided atrium is the morphological left atrium. The way to look at it, the same as we do in pediatric, you can look at the atrial appendage, and the usual rule as the atrium which is in front of the aorta is the left atrium. One should ensure that the foramen ovale flap is in the left atrium, because in the fetal heart, the patent foramen ovale is open and the flow is from right to left. So the flap should be opening into the left side of the atrium, and atrial septum primum is present, and pulmonary veins are entering into the left atrium, one should ensure. Similarly, in the ventricles, they should be also more or less equal in size in the mid-trimester, and one should ensure that which is right ventricle, which is left ventricle. We all know the points. Ventricular function, we can look at the squeezing of the ventricles, or you can use other methods to find out the ventricular function. I will come into that in my later slides. Moderator band should be in the right ventricle, and one should ensure from different angles that the ventricular septum is intact. Now, just by looking at these two pictures, the apical 4-chamber view and the lateral 4-chamber view, you can identify all the points we have just described. You can see the foramen ovale flap here opening towards the left atrium. To the left atrium, and you can. It is always better to look at the ventricular septum from the lateral 4-chamber view, because in the apical 4-chamber view, often you may find a dropout of the echo in the basal septum. So you should always confirm that it is, whether it is a VSD or not, from the lateral 4-chamber view. Atrioventricular junction and valves are also very important. So one should ensure that the cardiac crux is intact. Both the atrioventricular valves are at a different level. Tricuspid valve is more towards the apex, and they are opening and moving freely. Again, two 4-chamber views. I have purposefully kept these pictures. If you compare with the previous pictures, the quality of the picture is not that good. This is also done in a very good machine, but this is from 2015. So you understand the technology has also advanced over the years, and in 7-year time, the ultrasound technology has advanced, the fetal echo quality of imaging has advanced a lot. Let us go to the outflow tracts. If you look at these two pictures, this is a picture where you can see the outflow tracts from the left ventricle, the left ventricular outflow tract, aortic valve, and from the right ventricle, you can see the crossover of the great arteries, the aorta and pulmonary arteries crossing each other, and you can see the still image, the branch pulmonary arteries here. So you should ensure that the branch pulmonary arteries and the ductus, the pulmonary artery usually divides into 3 branches in the fetus because the PDA is open. Next very important view is the 3-vessel and 3-vessel trachea view. This is relatively new terminology to those who are used to pediatric echocardiography, because this is used mainly by the obstetricians and fetal ultrasound. It has become a more or less routine screening part in most of the centers. So this is nothing but a cross-sectional view of the superior mediastinum. And what you can see is that there is a V formation by the ductal arch and the aortic arch, and this is towards the left of the trachea. That confirms that it is a left-sided aortic arch, and both the ductal arch and aortic arch more or less equal in size, and the relative position of the great vessels in the superior mediastinum confirms that the great vessel relationship is normal and there is no significant narrowing of any of these outflow tracts. Another advantage of fetal echocardiography is that we get very good views of the vessels which are coming out of the heart. In pediatric or adult echo, it is difficult to image the great vessels. But in case of a fetus, it is very easy, and we get very nice pictures of the aortic and the pulmonary and the systemic veins. So you should always look for these structures. And in addition to the 2D imaging, M-mode, color flow mapping, and assessment of rhythm are very important part of fetal echocardiography. So you can look at these pictures and you can see that this is a aortic arch. In fetus, we know that there are two arches. One is the ductal arch, that is the patent ductus arteriosus. So the pulmonary artery, in the right lower image, you can see that the pulmonary artery is continued as PDA and then into the aorta, that is the ductal arch. And in the right upper image, you can see that it is the aortic arch. How to differentiate the two? You can find it any of the books, and you can see the SVC and IVC draining into the right atrium in the other picture, which is called the bicaval view. Similarly, we see in the transesophageal echo bicaval view, it is the same, and you can see the whole of the IVC starting from the abdomen. This cursor is not showing there. So this is basically the bicaval view. So this is the IVC which is draining into the right atrium. This is the SVC which is draining into the right atrium. Similarly, you can see this is the aortic arch which is arising from the middle of the chest and going down. And this is the ductal arch, pulmonary artery arising just behind the sternum, which is a more anterior structure, and it is continued through the PDA into the descending aorta. So this is the ductal arch and this is the aortic arch. So you will never be able to get such nice images in a child or in an adult. This is the images in a movie, basically, the still images. This is the aortic arch. You can see the branching of the aortic arch, the great vessels which are going into the head and neck. And this is both the aortic and ductal arch in the 2D. I'll just speed up because of lack of time, and I'm covering the whole of fetal echo, which is really difficult. Now, after that 2D images, let me just introduce a few slides of color Doppler and its importance. So if you look at these pictures, all are basically different four-chamber views, and when we apply the color, we should see the septum in full, because this is the best view to assess the ventricular septum, because the 2D image and the color flow images will never miss a VSD, muscular VSD here. Definitely we don't see the perimembranous VSD in this view. We need to open up the outflow tracts and look for the perimembranous VSD. And in this picture, you can see the flow through the patent foramen oval as well. And in this one, you can see the pulmonary veins. This is the left atrium. You can see the foramen oval flap to the left atrium, and these are at least two pulmonary veins draining into the left atrium rules out that there is no total anomalous pulmonary venous drainage. Similarly, if you look at the arch, this is the aortic arch, and you can see the color nicely, and this you can see the head and neck vessels arising from the arch as well. And this is the ductal arch, as I mentioned, and this is aortic arch again. So this is three-vessel trachea view. As we mentioned, this is the ductal arch, this is aortic arch, this is trachea, and this is the SVC. So these are forming a V, and this is the left side of the fetus that we have already determined. So this is the left-sided aortic arch with a normal V pattern of the great vessels. These three vessels, if they are normal, they are more or less equal in size, rules out any important outflow tract obstruction. So this, after the color flow, let me just discuss the importance of Doppler. If you look at this picture, the aortic, this is the left ventricular outflow. This is the aortic valve, which looks a bit more prominent, and when we are putting a color flow mapping, you see that there is some turbulence in the left ventricular outflow. So that gives us a suspicion that there may be an aortic obstruction. And if we put a pulse Doppler wave in the just above this aortic valve, the velocity of the blood is about 2.5 meter per second. That confirms our initial finding that it is aortic stenosis. One important aspect of fetal echocardiography is to determine the rhythm. Definitely we can't do an ECG in a fetus. So the way to find out the rhythm is to interpret the rhythm from the mechanical counterpart of the ECG. And as we know that if we look at the zoomed pictures, this is the E wave and A wave, which you all are familiar during assessment of diastolic function. In the fetal heart, always the A wave is bigger. And this corresponds to the atrial contraction. And this is the ventricular contraction. So we know that each atrial contraction is followed by a ventricular contraction. Each atrial contraction is followed by a ventricular contraction, which confirms that this is, we cannot say that this is sinus rhythm, but at least the atrial contraction is from a site which is within the atria and which is basically being conducted to the ventricle, and there is a 1:1 AV conduction. We can get a mechanical counterpart of the PR interval or AV interval, and we can determine whether there is any heart block or not. I am sure Dr. Debosmita will show the abnormal rhythm also in her presentation. In addition, we can place the pulse wave Doppler cursor either into the left ventricular inflow and outflow junction, where we can pick up the A wave and the V wave, or we can do a SVC and aorta Doppler, where we can find out the reversal of flow in the pulmonary vein, or SVC. So there are different methods. The most useful and what I personally use is this one, where we put the cursor in the left ventricular inflow-outflow junction and we get a simultaneous inflow Doppler as well as the outflow Doppler. Similarly, you can use the M mode also to determine the rhythm. So if we put a cursor, put the M mode through the ventricle and the atrium, you can pick up the atrial contraction as well as the ventricular contraction, and you can say that this is likely a sinus rhythm because all the A waves are followed by a V waves. Again, ventricular function, you can use either the M mode, same like we do in the in the adult or pediatric patient, or you can use the Doppler to get the myocardial performance index. I'm not going into the detail again. Now, last is the 4D echo and stick. I'm not going into the details. I'm not showing any pictures as well because 4D echo has very limited use in particular specific abnormal hearts. And stick is a system where we get a 2D volume loop or a volume loop, and we can do a cross-sectional at our wish at different levels and get the different views. So, but basic of any advanced image technique is a very good 2D image. If we get a very good 2D image and we put a color flow mapping and use the Doppler as we have discussed in my presentation, I am sure that you will not miss any major cardiac abnormalities. So definitely it is getting more importance with advances in technology and available expertise. It is preferably done between 20 to 24 weeks of gestation. One thing is very important. Rather than getting the diagnosis very accurate, it is more important to understand the hemodynamics because that will give us the final outcome, management strategy, and it is very important to counsel the family. Say we find that this is a single ventricle physiology. So it is important to know whether there is a pulmonary stenosis or not, or whether this is an increased pulmonary blood flow or it will be a decreased pulmonary blood flow. What will be the immediate outcome after the baby is born? Rather than try to find out whether it is a LV morphology or RV morphology. So basic underlying hemodynamics is more important rather than a very accurate diagnosis in fetal echocardiography. And it is always better to have a joint session with with a fetal medicine specialist and a pediatric cardiologist because it is not possible for a fetal medicine specialist to know the details of the cardiac abnormality and to know the outcome and the prognosis. Similarly, it is always not possible for a pediatric cardiologist to know the other abnormalities outside the heart and what can be the genetic association and other things. So it is always better to counsel the family as a joint counseling with a fetal medicine and a pediatric cardiology specialist. I'll stop here and thank you very much for a patient learning.
Thank you, Dhritabrata, for a very nice and lucid presentation. I'm sure there will be many questions, but I propose to keep this after Devasmita has presented the cases because we are running short of time. So we'll be pile up the questions at the end.